We have started our general surgery subject and we have discussed the first four chapters. That is, in the first video, we have discussed the shock and hemorrhage and burns. In the second video, we have discussed the ATLS and blood transfusions. In this video, we will discuss the chapter number 5, that is aseptic technique and sterilization. Okay, starting, what are the important points that we will learn in this video? These are asepsis and antisepsis, decontamination definition, disinfection and sterilization. All the definitions of these three important topics, methods of disinfection and sterilization, and principles of use of prophylactic antibiotics. We will be discussing these important things in this chapter. What are different methods of preventing infection and combination of cleaning, disinfection and sterilization? Okay, let's define asepsis. What is asepsis? Term asepsis refers to methods of preventing contamination of wound and other sites by ensuring that only sterile objects and fluids come into contact with them. This is asepsis. Now, what is antisepsis? Antisepsis is use of solutions such as chlorhexidine, iodine, or alcohol for disinfection. Asepsis method and antiseptic methods. The comparison is here. Asepsis method, it is isolation precaution, hand washing, use of gloves, mask, gown, glasses, use of a disposable clean surface, staff health, hygiene and education, reusable medical devices and equipments. Cleaning is done with warm water and solvent or detergent, preventive vaccination, inoculation and medicine. Use of efficient devices for aseptic purposes. What are antiseptic methods? Chlorhexidines used for skin preparation and surgical scrub. Pyodine and iodine are used. Safe hand washing method. Alcohol skin preparation, hypochlorite skin preparation and hexachlorophene skin preparation. These are antiseptic methods. Now, what is decontamination? Let's define decontamination. Decontamination aims to eliminate or reduce levels of vegetative microorganisms and other unwanted materials from reusable medical devices, equipments, and surfaces. What are the methods for decontamination? Cleaning. Aim of cleaning is to remove contamination, for example, blood, tissues, body fluid residues, degradation products, pathogens, soil, and dust from reusable devices and equipments. Disinfection. Disinfection is defined as a process intended to kill microorganisms with the exception of bacterial spores. Classification: low, intermediate, and high. Low. Reduce overall number of microorganisms but does not destroy tubercle bacilli or bacterial spores. Intermediate disinfection kills tubercle, viruses, and fungi but only some spores. Disinfection of high kills most forms of microbes except for some spores. What are the methods for disinfection? These are chemical agents and physical agents. In chemical agents, we have alcohol, formaldehyde, 2% glutaraldehyde, 0.1% sodium hypochlorite. In physical agents, we have low temperature steam and boiling water. Alcohol is liquid, formaldehyde is gas, and the boiling water for soft water, boil 800 degrees C for 5 minutes. Okay, this was disinfection. Now coming towards sterilization. By definition, process destroys all forms of microbial life including bacteria, viruses, spores and fungi. What are the methods? The methods are sterilization by steam, autoclaving at 134 degrees C for 30 minutes, not for heat sensitive devices, at 121 degrees C for 15 minutes. Sterilization by ethylene oxide, non-corrosive gas, can use for heat-sensitive devices, highly cost. Sterilization by hot air or oven, used for fine-cut eats, for example, ophthalmic instruments, and temperature is 180 degrees C. Sterilization by low-temperature steam and formaldehyde at 73 degrees C, used for materials with integral plastic components. Sterilization by irradiation, using gamma rays or accelerated electrons. 2% glutaraldehyde used as disinfectant but also used for sterilization. Sterilization by periacetic acid, steris method involves liquid immersion, denature proteins destroy cell membranes by disrupting sulfur and sulfur sulfhydryl bonds. Works at 50 to 56 degrees C for 12 minutes. Okay, now what are the objects and what are the methods? Dressing material and gloves, catheters, syringe and IV cannula. Okay, for dressing material and gloves, we will use steam under pressure, that is autoclave. For catheters, syringe and IV cannula, we will use gamma rays. For fine cutting edge, for example, ophthalmic instruments, we will use hot air. For heat sensitive material, we will use ethylene oxide. For endoscopes, steris, that is para-acetic acid. For surgical instruments, steam is used. Artery, forceps, clamps and needle holder, pressure and temperature. For suture materials, iodine is used. For thermometers and stethoscopes, alcohol is used. For respiratory therapy equipments, formaldehyde is used. These are the methods for the sterilization of different objects. Now, what are the factors that contribute to asepsis in OT? These are patient preparation, surgical preparation instruments, and surgeon preparation. Patient preparation. Bacterial flora of patient is principal source of infection in surgical wounds. Showering with antiseptic solution, shifting with clean and gown and shift to clean bed. Shave surgical site, painting and draping antiseptic 10% iodine applied. Okay, for surgical instruments are cleaned, disinfected and sterilized, and surgeon preparation, hand washing, gloves, mask and hair cover and surgical gown is wear. These are the factors that contribute to the asepsis in OT. Okay, the fourth one is preparation of OT, surgical techniques and prophylactic antibiotics. These are also the factors contributing to asepsis in OT. Preparation of OT, dirty area should be prevented. Temperature regulate between 19 degrees C to 22 degrees C. Humidity 45% to 55%. Adjustable lights, air should be filtered. In surgical techniques, avoid poor tissue handling. In prophylactic antibiotic, pre-op antibiotics at time of anesthesia. Pre-op antibiotics, good surgical procedure, asepsis and good nutrition should be given, and post-op antibiotic prophylaxis, remove drain as early as possible, do the dressing, start enteral nutrition, glycemic control and short stay in hospital. What are the principal use of prophylactic antibiotics? This is one of the important topic. Prophylactic antibiotics should be administered for operative procedures that have high risk of post-operative surgical site infection or when foreign materials are implanted. It should be effective against aerobic and anaerobic pathogens most likely to contaminate surgical site, that is gram-positive skin or normal flora, cloning incised mucosa. Should be administered within 120 minutes prior to incision or should be given at time of anesthesia. So what we have discussed in this chapter, this is the chapter of aseptic technique in sterilization. What are the important things to learn? It is asepsis and antisepsis, the definition of decontamination, disinfection and sterilization, the methods of disinfection and sterilization, and principles of use of prophylactic antibiotic. First we define the asepsis, then antisepsis, then what are the methods of asepsis and antisepsis, then we discuss the definition of decontamination and what is the process for decontamination. It is cleaning, then disinfection, then what are the low, intermediate and high disinfections, what are the methods, what are the chemical methods of disinfection, what are the physical methods, then we define the sterilization, then what are the methods of sterilization. Sterilization by steam, by ethylene oxide, by hot air oven, by low temperature steam and formaldehyde, and by irradiation. Then 2% glutaraldehyde and sterilization by para-acetic acid. Then what are the different objects and what are the specific methods for its sterilization. Then we discuss the factors that contribute to asepsis in OT, which are patient preparation, surgical preparation of instruments, surgeon preparation, preparation of the OT, surgical techniques and prophylactic antibiotics. Then we discuss what are the principal use of prophylactic antibiotic. Now coming towards our next chapter, that is nutrition. What are the important points that we will discuss in this chapter? We will discuss the severe maxillofacial injury and its mode of nutrition. Then we will discuss the different methods of nutritional support, then the complications of nutritional support, and then comatose patient mode of nutrition. What is the mode of nutrition for a comatose patient? So starting from effects of malnutrition on surgical patient. First of all, it will delay the wound healing, then it will reduce ventilatory capacity, then it will reduce immunity and increase risk of infection, then it will prolong hospital stay, it will disrupt mucosal barrier and it will cause increased mortality. Nutritional assessment, how we will do the nutritional assessment? First we will do the clinical history, then we will do the physical examination, then we will check for the body mass index, that is BMI, weight in kgs divided by height in meter squares, then we will do the anthropometric assessment, then we will do laboratory test used for nutritional assessment. What is the specific formula for the calculation of energy requirement? It is basal energy expenditure in energy factor into activity factor. This formula is very important. You should remember this. How to calculate the energy requirement? Basal energy expenditure into energy factor into activity factor. Okay, now coming towards enteral feeding. What is enteral feeding? It refers to any method of feeding that uses GIT to deliver part or all of person's caloric requirement. Assessment should be done before embarking on enteral feeding. Small intestines should be functioning. Okay, what are the indications for enteral feeding? Protein energy malnutrition with inadequate oral intake, dysphagia for solids, unconsciousness, debility and anorexia postoperatively, enterocutaneous fistula, distal low output that is less than 200 ml, and for enhancing adaptation after massive enterocotomy. What are the contraindications? Small bowel obstruction. The enteral feeding is not done in the case of small bowel obstruction, in the case of paralytic ileus, in case of severe diarrhea, in case of proximal small intestinal fistulas, and in the case of severe pancreatitis. What are the routes of administrations for the enteral feeding? These are oral, NG tube, tube gastrostomy, and tube enterocostomy. Okay. Now, what are the methods for the enteral feeding? These are oral supplements or sip feeding, nasogastric or nasoenteric feeding, use of for duration of 6 weeks. Okay, tube gastrostomy and enterostomy is done for the these are the routes of administration or methods of routes of administration for enteral feeding. Nutrient formulation, polymeric liquid diets or elemental diet, rate of infusion and strength of initial feed. How we will formulate the nutrition? By liquid diet, by elemental diet, by rate of infusion and strength of initial feed. What are the advantages of enteral feeding and what are the complications? Let's discuss. The advantages are prevent intestinal mucosal atrophy, maintain gut barrier function and decrease post of infections complications. Support gut associated immunological shield, alternate hypermetabolic response to injury and surgery, cheaper than total TPN and has few complications. No intravenous access is needed. What are the complications? Feeding tube, malabsorption, malposition, dislodgement or migration, aspiration, perforation of intestine, peritonitis, abscess formation, fistula formation, intestinal obstruction, tube fracture or blockage. These are the complications. Feeding regimen, these are the complications of feeding tube. Now, what are the complications of feeding regimen? Feed intolerance, that is diarrhea, vomiting, are common complications. Hyperglycemia, reduction of rate infusion along with insulin therapy provides effective treatment. Enteric infection, to prevent the complication, discard contain after 12 hours. So this was the enteral nutrition. Now coming towards parenteral nutrition. Parenteral nutrition is defined as provision of all nutritional requirements without the use of gastrointestinal tract. It is employed when there is intestinal failure, that is a reduction in functioning gut mass below minimal necessary for adequate digestion and absorption of nutrients. What are the indications for parenteral nutrition? These are absolute indications, proximal enterocutaneous fistula, and relative indications, that is mood or severe malnutrition, severe inflammatory bowel diseases, severe pancreatitis, prolonged ileus, abdominal sepsis, major trauma and burns, and massive intestinal obstruction. What are the contraindications for parenteral nutrition? These are congestive cardiac failure, blood sclerosis, uncontrolled diabetes mellitus, fat metabolism disturbance, and liver failure. What are the routes of administration? Catheters are used, peripheral or central vein. Peripheral is central catheters, and okay, what are the complications related to feeding catheter and related to feeding regimen? The complication is divided into two main classes related to feeding catheters and related to feeding regimens. Related to feeding catheters, problems of insertion, failure to cannulate, pneumothorax, hemothorax, arterial puncture, brachial plexus injury, mediastinal hematoma, thoracic duct injury. What are the problems of care? Catheter related infections, infective endocarditis, air embolus, central venous or cardiac thrombosis, thrombotic catheter occlusion, catheter migration or embolus. What are the complications related to feeding regimen? These are hyperglycemia, hypoglycemia, hypertriglyceridemia, electrolyte disturbances, hyponatremia, hypokalemia, hyper uh, uh, cholinic acidosis. What are the trace elements? These are the feeding regimen complications, trace elements, and vitamins deficiency, and the deranged LFTs and essential fatty acid deficiency. Okay, so what we discussed in the chapter of nutrition. These are the important topics, that is severe maxillofacial injury, mode of nutrition, different methods of nutritional support, what are the complications of nutritional support, and what are the comatose patients' mode of nutrition. The effects of malnutrition or surgical patients are these. Then what is then how to do the nutritional assessment, that is take history examination, body mass index, anthropometric assessment, lab test. What is the formula for the calculation of energy? So this is basal energy expenditure into energy factor into activity factor. Then we define enteral feeding, and what are the indications and what are the contraindications. Protein malnutrition, alcoholic dysphagia for solids, unconsciousness, that is comatized patient. So here we discuss that we have to discuss the comatized patient mode of nutrition. So in unconscious patient, enteral feeding is given. Disability, Russia postoperatively, and what are the contraindications? What are the routes of administration? Routes are orally, NC tube gastrostomy, and tube enterostomy. What are the methods? The methods are oral and supplementals, and the NC tube and the tube gastrostomy. The nutrient formulation. Then we discuss the advantages of enteral feeding and the disadvantages or complications. And the complications are divided into two broad spectrums, that is feeding tube and the feeding regimen. Then we discuss the parenteral nutrition, its definition, what are the indications and contraindications, and what are the routes of administration for parenteral nutrition. Then we discuss the complications related to feeding catheters and relating to feeding regimen. Okay, so this was our nutrition topic. In the next chapter, in the next portion, we will discuss the chapter gangrene and amputation and the wound. Our next task is the discussion of gangrene and amputation and wound. Gangrene and amputation. First, we will change the color of our highlighter. Which one? This one. Okay, I like this one. Let's start. In this chapter, we will discuss the most important things, that are causes of gangrene, what is the management for gangrene, male diabetic patient, foul smelling, ulceration on scrotum, bilaterally, severe pain in genitalia, high grade fever, Fournier gangrene, diagnosis, cause of organisms, treatment and complications. The diabetic patient, sudden onset of pelvic swelling of right foot, on examination, confused. Acha. Now, this is a scenario. These are the common and important things that we will be discussing. What is it? The diabetic patient, the sudden onset of painful swelling of right foot, on examination, confused. BP is 80/60, pulse is 120 per minute, temperature is 39 degrees C, right leg is swollen, and brown blebs are present. What are the causes, risk factors, management, and complications for gangrene and amputation? So, first of all, we will define what is gangrene. Gangrene. It is a microscopic death of tissue which is called gangrene. It is usually due to impaired blood supply and ensuring bacterial invasion. Most commonly seen in distal parts of limbs, loop of appendix, and small intestine. Occurs in gallbladder and pancreas rarely. Now, what are the causes of gangrene? These are secondary to arterial obstruction, infective, and traumatic. These are the causes of gangrene. What are the types of gangrene? These are dry gangrene, wet gangrene, and gas gangrene. Dry gangrene, wet gangrene. What are the causes of dry gangrene? It is slow arterial occlusion. Wet gangrene is sudden arterial occlusion. What are the involvements? Small areas due to presence of collaterals. In wet gangrene, large area due to absence of collaterals. What is the appearance? Dry, shrinkled, and mummified appearance. In the wet gangrene, it is wet, turgid, and edematous. What is the line of demarcation in dry gangrene? It is usually present. In wet gangrene, the line of demarcation is usually absent. What is the crepitus? The crepitus is absent in dry gangrene. It may be present in wet gangrene. The odor is absent in dry gangrene. Foul smell due to hydrogen sulfide produced by bacteria is present in wet gangrene. Infection is absent in dry gangrene. Infection is present in wet gangrene. The disease are Burgers disease and atherosclerosis, while in wet gangrene it is emboli, ligature, and crush injuries. The treatment for dry gangrene are conservative amputation, while the wet gangrene are major amputation. Okay, what are the clinical features for the gangrene? It is pain at injury site, swelling, high-grade fever, blisters with brown fluid, tachycardia, sweating, and some subcutaneous emphysema. Now, what are the causes, risks, and management and complications? What are the causes or risk factors for gangrene? As a result of infection with Clostridium difficile, loss of blood flow due to atherosclerosis, diabetes, heat, injury, smoking, Raynaud's phenomena, obesity, bed sores, corrosive acids, and Burgers disease. These are the causes or risk factors for gangrene. What is the management? First of all, we will take the history, that is relevant history regarding diabetes, hypertension, smoking, other associated conditions. Then we will do the clinical examination of diabetic food, that is temperature, pulsation, color, and sensation. Then we will do the investigations, that is urine and blood sugar, to exclude diabetes mellitus, culture and sensitivity of pus, that is Clostridium difficile, X-ray of gangrene to exclude bony involvement. Doppler is done, blood culture for bacteria is done, Doppler scan is done, and CT MRI which may showcase. Now, how we will treat it specifically? We will provide the general treatment and the specific treatment. In general treatment, control of diabetes is done, foot care is done, improved hygiene is done, analgesia, non-opioids are given, and keeping gangrene dry. In specific treatment, we will assessment of involved areas and blood flow to foot and loss of sensation, temperature, pulsation, discoloration, and sensation assessment. Then we will do the treatment, that is removing dead tissue, treating and penetrating conditions that cause gangrene, recovery of site of dead tissues depending on type and extent of gangrene. The treatment options are surgical debridement, amputation, maggot therapy. Okay, now coming towards fournier gangrene, we have discussed the dry gangrene and the wet gangrene. Now coming towards the fournier gangrene. What are the clinical features for fournier gangrene? The patient will be diabetic patient, foul smell will be present, ulceration on scrotum, bilaterally pain in genitalia, or high-grade fever. We will learn the diagnosis, causes, treatment, and complications of fournier gangrene. What is the definition of fournier gangrene? It is a type of necrotizing fasciitis, or one can say it is a synergistic involving genitalia and perineal region. What are the causative organisms? These are Streptococci, Escherichia coli, Staphylococci, Klebsiella, Pseudomonas proteus. What are the complications and differential diagnosis? The complications are acute respiratory failure, acute respiratory distress syndrome, septicemia, heart failure, UTI, and stroke. What are differential diagnosis? Cellulitis, case gangrene, necrotizing fasciitis, orchitis, testicular, torch, and epididymis. These are the differential diagnosis of fournier gangrene. Now, what are the treatment options? First, we will provide the general treatment, then the medical treatment, and then the surgical treatment. The general treatment is adequate hydration, electrolyte balance, glycemic control, and hygienic improvement. The medical management is broad spectrum antibiotic, that is ciprofloxacin and metronidazole, irrigation with superoxidized H2O, intravenous to neutralize antigen is toxin A and B. Intravenous IG is given. The surgical is debridement, reconstruction after infection of testes are exposed, cover them with skin by grafting. Vacuum assisted closure is done. So this was the case of fournier gangrene. What are the causes? What are the complications? What are the DTs? What are the treatment options? What is the general, medical, and surgical treatment? Now coming towards the case gangrene. The definition is okay. What are the clinical features of case gangrene? There will be diabetes mellitus, sudden onset of painful swelling. On examination, he is confused. BP 80 by 60 mm of Hg. Pulse 120 temperature 90, right legs swollen, brown blebs are present. In case gangrene, the clinical features are fever, septicemia, and crepitus. The definition of case gangrene is also known as myonecrosis. It is a bacterial infection that produces tissues case in gangrene. It is caused by Clostridium perfringens bacteria. What are the organisms that cause case gangrene? These are Clostridium perfringens, Staph aureus, Vibrio cholera, and group A Streptococci. What are the risk factors for the gas gangrene? These are diabetes, obesity, vascular diseases, alcoholism or malignancy, or HIV and smoking. What are the management options for gas gangrene? These are history, wound related problems, and fever and pain. Then examination is done for limb of swelling, joint redness, and abscess. Then palpate, temperature, tenderness, crepitations, and sensation, and movement of limbs is checked. What are the investigations that are done for gas gangrene? These are CBC, arterial blood gases, blood glucose to exclude diabetes mellitus, blood culture is done for wound culture, X-ray limb fractures gas, MRI, RFT, LFTs, LSR test, PCR, and serum cholesterol is done in the case of gas gangrene. What are the treatment options? First of two, O2 to decrease bacterial growth, fresh blood transfusion is done, injection benzyl penicillin 20 lakh units and 4 orally plus metronidazole 500 milligram 8 orally plus injection aminoglycoside, anti-gas gangrene serum 100 centimeter daily, anti-tetanus vaccine is given. What are the surgical options? Debridement of skin graft and amputation. Instant complications are massive hemolysis, DIC, ARF, ARDS, and shock. What is the amputation? How amputation is done? Amputation is done for deadly, and dead loss. What are the types of amputation? These are toe amputation, ray amputation, transmetatarsal amputation, midfoot amputation, Simus amputation, Gulliton amputation, below knee amputation, and above knee amputation. Post-op care and complications, early and late of amputation should be read from the book. Okay, so what we have discussed in this case and gangrene chapter. Uh, Gangrene and amputation. First of all, we discuss what is gangrene, what is its definition. Then we discuss what are the causes. Then we discuss the types of gangrene, which is dry gangrene and wet gangrene. We have compared both of it. We have studied the causes, involvement, appearance, line of demarcation, crepitus, order, infection, and disease treatment. Then we discuss the causes or risk factors of gangrene, and then what is the general management for gangrene. We will take the history of the patient. Then we will do the clinical examination and investigation. Then we will treat the patient. First, we will provide general treatment, then specific treatment, and the treatment options and the surgical treatment options. Then we discuss the Fournier gangrene. What are the clinical features of the Fournier gangrene patient? Then we discuss the organisms that cause it. What are the complications, the differential diagnosis, and what is the treatment option for gangrene. What are the general medical and surgical measurements to do for the Fournier gangrene. Then what is gas gangrene? What are the clinical features and what is the definition? What are the organisms that cause the gas gangrene? What are the risk factors? What are the management options? What investigations are done? What is the treatment options? What are the surgical complications of the gas gangrene? Then we discuss what is the amputation. What are the types of amputation? What is the post-op care? What are the complications of early and what are the early and late complications of amputation? In next section, we will discuss the chapter wound, and then we will discuss the chapter chronic like ulcers.